Hello, everyone. My name is David. Great to see everyone. Je veux commencer en français parce que je veux dire, si quelqu'un veut nous donner un commentaire, une question en français, s'il vous plaît, n'hésitez pas. Don't hesitate to speak in French, in Mandarin, in Spanish, Czech, what else? We'll do our best to be multilingual.
Ukrainian.
Ukrainian. Ja taky mluvím česky. Ano, můžeme povídat po ukrajinsky trochu.
I can understand you. I can back.
So my name's David. Keith just made my day. He thought I was a medical student or a resident or something like that. I've been involved with the University of Ottawa since 1998 as a resident in family medicine. I'm now the interim assistant dean of global health. And it's a real pleasure to see you all here because we're trying more than anything to build community in many languages. It's an exciting time in global health. We've just hired Haley. Welcome. We have a great team. Leah's moving her file to BCDI, a big project that we have to make the Banan project more reciprocal. We have plans for a global health retreat, and we're planning for these events for next year. So if you have ideas, please, above all, stay in touch, restez en contact. And today we're really excited to have 4 learners, students, PhD candidates sharing their work. And that's what it's all about. It's all about community and looking forward to the future of collaboration. So with those words, I think we have a land acknowledgement and some introductions. Merci beaucoup et n'hésitez pas de parler en plusieurs langues.
Thanks, David, and welcome everyone. It gives me please note that the session will be recorded. This is mainly for us to be able to share the content of the session with whoever wasn't able to join us today. I'm going to start with the land acknowledgement. We pay respect to the Algonquin people who are the traditional guardians of this land. We acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people in the region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Just to give you a brief about the Global Health Learning Network. So the Global Health Learning Network is a platform for knowledge growth and exchange with the goal to build a community of practice in global health that reaches across researchers, practitioners, and learners from all global health domains to include members of the public with an interest in global health. This is a collaboration between the School of Epidemiology and Public Health, Briere Health, the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment and Health Equity, and the International and Global Health Office, who are collaborating to host this Global Health Learning Network series of events. This is our last event for this academic year, and we'd love to hear back from you. We'll be sharing an evaluation form at the end of the session. So if you have comments or recommendations for future events, we'll be more than happy to include them in our planning for next year. Just to share some of the learning objectives of this session. So we really want to showcase real-world experiences in global health through the lens of the UOttawa learners. We also aim to explore how health disparities and global health challenges are addressed in diverse regions of the world, and that's where we'll have to hear from different speakers and their experiences in different contexts to foster knowledge exchange and discussion on the future of global health practices and research. For those who are online, please add your questions in the chat. We'll have a Q&A session, which will be moderated by our moderator. And it gives me great pleasure to welcome our speakers and moderator for today. Our moderator is Mahalakshmi. I will introduce her in a bit. And I'd like to thank Jeremiah, Shanika, Keith, and Chelsea for willing to share their experiences. Mahalakshmi recently completed her Master's of Public Health at the Faculty of Medicine with a concentration in policy in December 2024. She's been part of the Global Health Concentration Program since 2023 and became a Global Health Student Ambassador in September 2024. That's how I know her. Her favorite aspect of the concentration is the opportunity to network with global health leaders and gain valuable insights from their experience during Global Health Learning Network session. Mahalakshmi also appreciates participating in interactive workshops such as the Empathy Project, which offers a first-hand immersive learning experience focused on understanding health inequities and the challenges individuals face within the Canadian healthcare system. This would be our agenda for the day. Mahalakshmi, would you like to introduce the different sessions and speakers? You hear us
Yeah,
okay?
sure. Yeah, thank you, Leah, for the warm introduction. So our first speaker is Jeremiah Achari Basam. So he will be talking about bridging gaps, so integrating mental health services in NTD care in Ghana. Our second speaker is Shanika, who's also from my MPH cohort. She will be talking about her practicum experience, examining global health partnerships in Tanzania. Our third speaker is Keith, who's a third-year medical student at University of Ottawa, and he will be talking about TAPE. And lastly, we have Chelsea, who's a second-year medical student, and she will be talking about shifting attitudes towards substance use, health, and stigma. So we can go ahead with the first presentation. So our first speaker is Jeremiah, and he's a PhD candidate in epidemiology here at University of Ottawa, where he explores the nexus of health data analytics, neglected tropical diseases, mental health, and disability within community health frameworks. His academic foundation in psychology, telemedicine, and community and population health sciences enables a comprehensive approach to global health challenges. His thesis work centers on improving healthcare access for marginalized populations in Ghana, particularly those impacted by neglected tropical diseases such as lymphatic filariasis. He champions the integration of mental health services into routine healthcare systems, advocating for holistic and accessible care. His research is aimed at influencing policy and cultivating inclusive practices that meet the complex needs of communities affected by NTDs and related disabilities. So on to you, Jeremiah.
Yeah, thank you everyone for making it. Thank you for taking the time to come here today and listen to us. Without wasting too much of your time, I would like to delve into part of my work. And the reason for me going to Ghana specifically was because I wanted to speak to stakeholders, because part of the, as individuals working within scientists and also within community healthcare and stuff like that, it's very important to usually speak to stakeholders on the ground to understand the priorities and the needs of the populations you are trying to help. And so that was part of the reason why I went to Ghana, and through the help of the IGO funding, I was able to successfully travel to Ghana, speak to stakeholders, and that sort of helped to shape my PhD thesis. And I would highly recommend that for anyone who might also be going through the same process of travel, speak to stakeholders, and then get to understand their priorities. So in terms of my presentation today, it's brief. I would just like to talk through these couple of items on my slides, starting with an introduction to give you sort of like context into why I'm doing my study and the purpose for my travel. And then also to talk a little bit about intersections, which is sort of like those relationships between, being disabled, having NTDs, and then also access to healthcare and stuff like that. And also just to speak a little bit about my travel to Ghana, and then of course, leave you guys with maybe a take-home message that might get a few of you to sort of like start to advocate for these populations. So on this slide, you would see that when we talk about NTDs, they fall within different categories. And as you can see there, some are bacterial, others are viral, fungal, and other things like that. And so you have individuals who are suffering from these these conditions within especially tropical regions around the world where these conditions are predominant. And so some of the quick facts about these NTDs is that for one, about 1.6 billion individuals around the globe directly affected by these conditions. And as you can see, as I said, they're often prevalent in tropical contexts where you have those countries close to the equator. And so some of the impacts of these conditions is that, of course, they do occur within populations that are impoverished, populations that are deprived, always populations that are marginalized within these communities. And so they can lead to severe sort of disability as one of their impact, and also a lot of suffering within these populations, which are already in the borders of society, which are marginalized. And so this was part of the reason why I became interested in this, because my background, as I said, is in mental health. And when you look within the NTD programming space, this is an area that has also been, even though we are dealing with neglected diseases, but this is an area that has been neglected. And so Ghana, the country where I went to, and I'm also from Ghana, is endemic for about 14 of those NTDs. And as I said, they cause significant, sorry for the image, but I thought it might sort of help me to hone down sort of like what I'm talking about. So these are some of the symptoms of skin-related NTDs. And as you can see, as an individual who is already at the margins of society living with this, right? You are kind of excluded from society when it comes to socioeconomic activities, you are not involved. Social participation is also affected because individuals might avoid you because of your symptoms. And so, as I mentioned, this has several impacts. One of them is, of course, as you can see, the physical disabilities that come with these conditions, right? Which can lead to some of those. You can see the lymphedema, which is part of what you saw. Lesions on the skin, which can open the skin up for other infections, like we call them secondary infections, hydrocele, leprosy, and I'm sure you are familiar with some of them. The other part of it, which has been neglected, as I mentioned, is mental disability, which often is as a result of the physical disabilities and the consequences, the social consequences of having to live with that. So things like depression, suicidal ideation, isolation, anxiety, and many, many, many others, which have been found by research. These populations are suffering from some of these conditions. And the third, which I'm interested in, is how does this interplay between those two dimensions affect one's access to healthcare? Of course, you can expect that if you are neglected from social participation, it might also, because healthcare is part of what? It's the social dimension on its own, right? So if you are isolated from participation in community activities, economic activities, we can expect that it might also impact your access to healthcare. And so my interest, the interest of my PhD is on that third box to the right, where I want to see how those interactions are impacting people's access to healthcare. And so down there, I had a little bit of text blurb that kind of tells you a bit about the interplay, the consequences of those interactions between the conditions. And as you can see, when you have conditions, number one, that occur among people who are impoverished, people who are at the margins of the society and have limited access to social, resources, economic activity, education also. And then you also have these individuals suffering from mental health, which further sort of pushes them towards the margins of society, because mental health is also a stigmatized condition, right? So this is sort of like a magnified effect. And then that leads you to being discriminated at the hospitals and local facilities and things like that. And so this can further reduce your access to good quality healthcare, which can lead to further exacerbating your conditions. And then you kind of have this spiral vicious cycle of poverty, disease, suffering, and the rest. And so this is kind of the reason why I became interested in this topic. And so just to talk a bit about the background of my visit to Ghana now. So the reason was to go talk to stakeholders, as I mentioned, to understand their priorities and then incorporate that into my research. As community health researchers, it's good to speak to stakeholders to inform your research. And so when I went to Ghana, these were some of my objectives. And I went in August last year, and I went to these locations in Ghana, and then these were some of the stakeholders I spoke to. So from the Ghana Health Service, which is sort of like the national level, all the way to local stakeholders, and then the district assembly officials and other individuals, even including those who, I spoke to some of the individuals who were actually having disability, and then were facing some of those conditions I mentioned. And when I went to Ghana, these were some of the things I found. One of them is that there's a gap, as I mentioned. Mental health is neglected within NTD programming. And so that has created, part of the reason for that is because of the barriers. Individuals don't have access to mental health care, and mental health itself is also a stigmatizing condition. And so what I realized is that, one, the barriers do exist. And then there's also insufficient kind of interaction between the different sectors. So we have the Ghana Mental Health Authority, which is kind of in charge of mental health services in Ghana. We have the Ghana Health Service, which is the other block, which is in charge of regular healthcare, routine healthcare, and these are not talking, right? So that is creating sort of a trickle-down effect, which is creating service gaps in the country for especially these patients. And so they did mention that significant funding is an issue. Limitations in funding is part of the reason why they are not able to sort of cross that lines in terms of like having conversations, introducing programs that can sort of cater for this gap. And healthcare workers also lack training when it comes to mental health training. As you can see, the conditions, they are very stigmatizing. Some of them might come with a lot of stench, right, because of the source and the lack of hygiene. And so healthcare workers might discriminate against these patients when they go to hospitals, which kind of like pushes them away from trying to access healthcare. And then the other thing I found was that there's a need for research, advocacy, awareness creation, community engagement, and of course, all of these, when they come together, would help us to sort of advocate for these individuals and then to have kind of reach some of these gaps in the process. And so my take home is that it's important for us to introduce mobility management programs into NTD programming, and then even national healthcare agenda. And then also by supporting these inclusive initiatives, it would help us to not only alleviate suffering, but also to create a society which is inclusive, which sort of welcomes individuals on the margins of society. And then hopefully maybe this can lead to better well-being, quality of life, and other things like that for this individual. So thank you. I know I rushed through it, but thank you so much for listening. And I'm happy to take questions as well.
I'm just curious, for your trip to Ghana, I see you identified people at different levels of government. You identified 12 different people. How did you go about like identifying those specific stakeholders? Did you already have connections in Ghana that you were able to tap into, or what was your process?
Yeah, both of those. Yeah. So before I went, yeah, that's a very good question. Thank you for that. Before I went to Ghana, of course, I come from Ghana. And so I worked in the mental health care space for some time. So I already knew some of those stakeholders. I understand some of the issues on the ground, right? But one of the things I would say is that one, don't be blinded by the fact that you come from that region, right? Because then we often think we know because we come from there. Actually, I don't have any disability. I'm privileged not to have that, right? So I can't speak on behalf of those who do. So it's important for me not to assume I know, but then to actually go there and speak to them, despite the fact that I come from there. So my connections I have established over the years helped. And then so it helped me to sort of have a good frame of who to talk to, right? But in order to invite everyone who might actually contribute to the research in a way that captures the situation was to also speak to some of those individuals I knew who were working in the mental health space, who were working in Ghana Health Service, and then they also suggested some of those stakeholders that might have something to say, which would actually help inform my research. And so when I went there, part of the thing I did was that after every interview, I would be like, who else do you think I should talk to about this topic? And then they would sort of point me to the next person. So that also helped. And when I was done, I spoke to more people than I had planned. So yeah, I would say that helped, a little bit of both. Yeah. Thank you. Yeah.
Unless there are questions online, I have a reflection question. I've often spoken to Alison Krentel about this one. You know, we've all heard of the differences between horizontal programming and funding, fundraising as compared to vertical or disease-specific programming.
Yeah.
And it maybe paradoxically, since the pandemic, we're seeing more, I think, vertical programming again. And it's paradoxical because the pandemic was very much a whole of society phenomenon. Some reflections recently is maybe we need both. And that's what your project is about. you looked at a disease-specific project from a sort of access and mental health access point of view. And I guess my question is, how do we sell that message, or what are some of the personal lessons you've had to help sell that message? Because horizontal programming isn't, if you will, for lack of a better word, always sexy to fundraisers. It's not easy to explain. It's not concrete.
Yeah.
So I'm not sure if these are reflections you've also had, but can you help us sort of sell the message that we need both, including that horizontal primary care programming?
Yeah, no, thank you very much. Yeah, I think that's a very important question. And as you mentioned, since the pandemic happened, right, it's like funding limitations, so many reasons now, like individuals already were not supporting the idea of the horizontal programming. And so when the pandemic came, it was a good reason to just latch onto and then, stick by what they already initially had, always supported. So in terms of messaging, I would personally, and then even speaking from my interviews and then speaking with Dr. Allison and the rest, one of the things is that community involvement, I think, is one of the things, because one of the things I realized when I spoke to the president of the Association of Individuals with Disability, was that there were political interference even in the allocation of things like wheelchairs and who gets to be on the list of social services and stuff like that, right? So I think for us governments, of course, would have to support the idea of the horizontal program. And as I mentioned, at the higher level is the mental health authority and then the Ghana Health Service. And so to influence those, often it's always the politicians at the end of the day, right? Who, because Ministry of Health is part of the government, is part of the arms of the government. And so the government does have a lot of influence, and NTD programming has gone from the angle of, let's go in there as external, healthcare personnel and try to change things, to the idea of, work with the authorities within the government to then sort of trickle down the interventions. And we've gone with that for some time. So I would say that maybe approaching this from a community level, getting, community level, getting individuals like those I spoke to who are actually living the condition and suffering from them, the fact that I have a disability, I also have to go to the hospital to get medication. And then I have to access mental health because I am isolated, right? I'm suicidal, like in terms of suicidal ideation. So they see those gaps, right? But those are authority level in terms of those actually in charge of making policies, often are disconnected from the grassroots. And so I would say that to influence the top level, we must, sort of connect with the grassroots, speak to them, create that awareness. And then from that, we can sort of create that momentum for which can then sort of trickle up, because they would listen to them because their constituencies, right? They vote for the individuals who sit in government. And so I think that gathering the momentum, political action is of course one of them, advocacy in terms of health advocacy and things like that. I think it's from that community level, probably we might be able to sort of hone in the message that is important to look at the person as a whole and not just, vertical programming. The person has lymphatic filariasis, and so let's give them medication and then that's it. Because you have someone with lymphedema, which might not recede, right? Because after I'm treated, I still have the elephantiasis and it doesn't go anywhere. I have to live with that for the rest of my life, right? So that individual understands that they need mental health because they are facing stigmatization, right? But if I were a policymaker who doesn't have that condition, like I said, I might not be able to sort of understand that. And so having that action from the grassroots myself has to turn those, tables around and then create that horizontal program. I think, yeah.
Thank you very much.
Yeah.
So what's next in your research now? Are you moving on to a different topic, or are you sticking to the same one, just extending it a little bit more?
Yeah, I'm not done with my thesis yet.
Okay.
So
Oh, so you're still on the same thesis?
yeah, but this was sort of preliminary work to kind of inform my thesis, the objectives of my thesis. And so now I feel like I have a very solid idea about what is happening on the ground, and my objectives kind of reflect some of the realities on the ground. Not everything, of course, because it's a thesis, I can't do everything, but at least to some extent, I feel like it reflects some of those realities on the ground. So the next step is in my ethics application stage, which you all know. And so hopefully once I'm through that, I will start to do some of the research. And I've connected with some NGOs that are already working in Ghana in this space. There's one in the UK, which is working to sort of work with the government, of course, to create integration of mental health into some of the entity programming. And so we kind of started connecting on that. So my findings in terms of access to healthcare might feed into that kind of research. We also have some who are kind of tracking lymphedema, doing clinical trials and other things. And so creating those connections in the grassroots, like those who are already there, working on that problem. So those are some of the things I'm doing now. Next couple of yes, yeah. Thank you.
Thank you, Jeremiah, for your valuable insights. Next up, we have Shanika. Shanika is a second-year MPH student in the global health stream. As a midwife, she has worked in sexual reproductive health and gender-based violence in New Zealand, Uganda, and Bangladesh with Doctors Without Borders, and she's currently working part-time in Northern Ontario.
All right, good evening. Yeah, so I'm Shanika. I'm a second-year MPH student, and I'll be talking about my practicum position with IGO that I did over the summertime as part of my Master's of Public Health program. I'm in the global health stream, so there's 3 different streams in global health, so this is quite fitting. So the things that I'll be chatting about today are the practicum position and what was my responsibilities within there, the tasks and the projects, my day-to-day and the nice balance of work and play that I had while being in a new place, and then my reflections and takeaways from that experience. So within IGO, my position was 3-pronged. So the first was support and coordination for 6 medical students from l'Ottawa during their community elective in Tanzania. So I was in Tanzania for a couple of weeks before they arrived, and just that point person on the ground to help out with the day-to-day activities and making sure that things went well with getting to the right places, as well as daily check-ins and debriefs there. The bulk of my time was spent carrying out a midterm evaluation of equity that exists between Ottawa and KCM UCO. So that's Kilimanjaro Christian Medical College. We have an institutional partnership with them, a preferred partnership, and that's 5 years, approaching the 5th year. And then lastly is a bit of everything with programming support for IGO. So IGO does a lot of work on the side that helps and enables students to do global health internships, placements, research endeavors, and just about kind of anything that falls under that umbrella. So a piece would be departure training, pre-departure training for people who are going outside of Canada, and just readiness there is advised, as well as putting together some material on the other end for when they come back. And then there's just a lot of logistical coordination that is involved with bilateral movement of people coming here to Ottawa, and also students going and leaving. So most of my time, like I said, was spent on looking at this idea of the equitable partnership that exists between KCM UCO and l'Ottawa Faculty of Medicine. So this MOU was signed in 2001, and it was a response and part of the strategic plan of the Faculty of Medicine to student requests for global health experiences. And then as we approach the midterm, it's a really good point to check in to see where are things at? Are we where we had hoped to be? Are we really fulfilling what our shared goals were? And part of the start of this relationship started with both sides sitting down and creating a logic model of what are we looking for in our relationship. And in Tanzania, Moshi, it was about increasing equity of healthcare within the region, as well as increased research. So Dr. Alison Krental was mentioned earlier, and she was responsible, or a big piece of this FAIR report that was created. And it looks at how, especially with University of Ottawa, how do we do global health partnerships well? How do we do institutional partnerships when you have a linking of a high income country, an institution in a high income country, and an institution in a low middle income country. And we know that a lot has changed and evolved in how we see global health, how we see partnership, and really making it more transparent and taking a deeper look at power differentials that may exist and how do we prevent those. The evaluation really focused on the principles of equity. And in of itself, I learned that the opportunity to carry out this midterm evaluation was just a space for a dialogue and a check-in moment. So we have these counterpart person-to-person relationships in different specialties of medicine, in research between, biostats from researchers on both sides. But when you think about how busy we are, we sometimes don't just get the chance to check in on like, how are we doing with how our work is being conducted together, or the things that we need to pivot on. So it just provides that space so that when we get to the end of the 5 years, we're not kind of like, oh, that's not kind of how we envisioned it to be. So the first thing I did before I left was just even looking into like what has happened over the past couple of years and to do a mapping of sorts. So the first thing was just mobility. So a big part of the partnership that exists is about mobility. So having folks from Tanzania come over here and seeing how we practice at the hospital, how we practice within CEF, how we practice in different departments here, and vice versa. So as you can see, it started in 2021 and a scope revisit happened shortly after that. And that's where we had clinicians from different specialties heading over to Tanzania to see where can we brew up some work together. The red is faculty mobility and the blue highlighting is student mobility. And there, for the past couple of years, there has been a really good movement between medical students from KCM UCO and medical students from Ottawa rotating, as well as Masters of Public Health students for research. The light blue is where people from Tanzania have come to our way. And you might notice, wow, there's a lot of dark blue, which means we're heading there a lot. And a piece of that exists is also because of visas and some extra logistical considerations. So what I was able to do is to see which specializations are really coming to the surface and having strengthened relationships where we can see some long-term outputs happening and some good concrete activities. So I was able to meet with the clinicians here in Ottawa to see like, hey, what's going on? How are things going? And then I was able to meet with their counterpart when I was in Tanzania at KCM UCO and at that medical college and hospital there. I met with 9 different people, going from an obstetrician to a surgeon to a biostatistician to the head of public health, the Institute of Public Health, and able to have a up to 1 hour interview with them, and in a semi-structured interview where I followed, taken from the FAR document, is this principles of partnership equity tool. So there's 6 different questions and it follows kind of 6 different domains of what's considered appropriate in a partnership. So that falls under integrity, transparency, alignment and harmonization, accountability. So these kind of topics here. And then I also had a intro of what do you know about our preferred partnership at the high level. And then a last question I added in was very open-ended, of seeing like, what do you dream about in this partnership? What would you hope for your department? And it was lovely to just listen. From there, just followed thematic analysis to come up with themes that came out of it. I didn't include all of them, just naming a few here. Though a couple are, one, mobility could consider specific departmental strategies. So some specialties are more tactile than others, and some specialties it would benefit a clinician coming over to Tanzania and working in that environment to teach a skill versus vice versa. Another one is finances are a rate determining step. We know that with any institution that finances are huge, and resources and where do you allocate those resources, as well as a huge awareness of with next steps in some ways, because you need the finances, that in some ways means that the higher income institution does have a little bit of directing that next step. Multiple channels of communication strengthens relationships. So it's really neat to see the specialty relationship that is formed. So that means within surgery, welcoming each other to each other's rounds online that is done, talking via WhatsApp, and just these informal ways of checking in with each other really seem to strengthen different departments. The collaboration is young. So when I inquired about trust and questions about that, the feedback I got is it's quite early days. So it's really hard to comment on a trust so early. And so relationships are really 5, 10, 15 years down the road. The last is delineation of general versus specialty capacity training. So, if you look at obstetrics, would we look at in Tanzania at KCM UCO of strengthening just quality improvement of all OBs, or would we look at the maternal fetal medicine program in Ottawa and how we could incorporate that in Tanzania with just a few clinicians? So it's always balancing, where do you want to send your resources, time, mentorship, finance. Finishing up with day-to-day. I loved it. It was a great experience. I had a really good crew. The med students were awesome. Julian's here today, and he also was in Tanzania. Just trying a lot of different food. Really connecting with the medical students in Tanzania who will also be joining us next month. So we look forward to hosting them and showing them around Ottawa. We have a house in Moshi, so we were able to have them over for dinner and just connect with them outside of the hospital and in some way try and reciprocate the hospitality that they were showing us. We really made use of the weekends and exploring and connecting with our friends that are in Tanzania. And last, I really enjoyed supporting the med students because they were just a fun crew and got to see that they were involved in different activities during their time. Reflections, it's just really important to listen to our institutional counterparts. Evaluations just provide a good check-in opportunity to do that. It's just space to check in. From a public health standpoint, I'm biased there because I'm in public health, but the medical students, it was a community placement. So I hope that in some ways they were able to see beyond the hospital and just the community networks that exist and NGOs and just how those are really important bridges to health and wellness that prevents people from not being in the hospital. From people coming into positions like this, I would always recommend not to be too serious, to just have open eyes, and just to observe, take in new opportunities, and to know that when you're in a new place, discomfort is inevitable. And sometimes we're just there to bear witness and to process that discomfort later. And also just knowing that we can't assume and that sometimes we just need to ask why another person, another system, another institution may do things differently. And we need to take that extra level of just kind of checking ourselves when we're in new places and spaces. And that, my friends, is the end.
I think I should start by highlighting that Shanika really did a fantastic job at supporting us and kind of facilitating our time in Tanzania. I think we're all super grateful that we had you there to kind of guide us through that. I'm wondering, I think it'd be useful if you have any advice to share with everybody in the room here. We're all, involved in global health in some capacity, on just like what are some of the things that you thought about when you were thinking about sort of guiding us through this journey and like preparing us to leave, running us through our debriefs, talking to us on the day-to-day. You have any advice for somebody that's going to maybe be in a role similar to yours in the future? Sorry to put you on the spot like that.
No, it's a good question. I think I was lucky in that I've had the opportunity to have been in the space of first time being on a placement and seeing healthcare in a different context and in a low middle income context. And I think it goes back to just like being willing to accept discomfort and maybe seeing things that are really just like bad healthcare given or just bad outcomes or just really sick people. And especially as first time over there, you're not changing anything. You're observing and you're kind of taking away what you learn there, but you're not there to act in some ways. You're just there to be a witness and to see how that's going to inform you and where you want to practice next, where you want to work in the future, and maybe at a systems level, how can we approach things differently?
Thanks.
Amazing, really great presentation. I'm curious, where do you work up north in Northern Ontario, and has this experience changed your approach with working with that community?
Yeah, so I work up in Marathon, which is like 3.5 hours east of Thunder Bay, serves about 3,000 people, 2,000 from 2 Indigenous communities. I was embarrassingly shocked by the poor health of the Indigenous people. And I almost had to, and we know about it, we read about it, but I almost had to actually put it in the same similar category in some ways to people who, we think about like Africa, or like we think about these countries that really have not enough resources, really stretched thin in many ways, and had to like understand like we have that in our backyard. Yeah, and it didn't feel good, but that's kind of the reality. I was really shocked.
I still work at Wapiscat, and
Yeah.
some conditions are, hard to imagine. My wife came once and she can,
Yeah, I mean, people always say all the time, like, you don't need to go overseas, you can just look in your own country, and that's like totally true.
but the community engagement you're talking about and just the listening and the patience, I found is quite helpful across contexts.
Yeah. Yeah, I think it does come back to listening, but to listen, we need to have time and space to do that. So how can we create that time and space? Question.
To echo that too, I think as a learner, especially too, in my experience going up to the Yukon, it was like, I felt like I was in an environment where there was a lot of resources and I could be sort of, not a leech, but almost a leech as a learner, because you're not really offering anything. And I think part of the reason I wanted to go to Tanzania is because of this reciprocal relationship, right? So it took some of that burden off me as a learner, I guess, knowing that my institution was providing something.
Yeah, no,
But it is a bit of a prickly pickle as a learner to like engage in some of these things and gain these experiences without being unethical about it, I guess. But
being a leech is a good example. Yeah, you learn and soak up as much as you can.
yeah,
Yeah, and I found it interesting that one of your reflections was that when you are there, you are there to just take it in, right? Don't try to process it there like you can process it later, but just observe, right? And I kind of find that interesting that like, even though I come from Ghana, right? And just comparing yours, coming from outside, you're not from that community, and then kind of like still coming to the same conclusion that sometimes when you go to these contexts, it's important to kind of like just observe, even regardless of whether you are from that community or outside. I found that very interesting. The question I guess I wanted to ask is, when you got there, what were some of those psychological tools, or maybe those, things that helped you kind of like ease yourself into this context?
Yeah. So part of like the tools, I would say the med students, like it or not, we work, like we do check-ins every evening. And I think just like the check-ins was really important. So one example is at the end of every day or every week, we did at the end of every week, we do a rose, a thorn, and a bud. So it was the worst part of the week, worst thing you saw or experienced or was part of. What was the best thing where you felt alive? And then it was a bud. What is something you're looking forward to, knowing what we have coming up? And that just seemed like a good way to like verbally process.
I think Shanika also really encouraged us to write down our thoughts too, to process them on our own time as well. And I think that was really, me personally, I think my always felt the same way too. But like taking a bit of time about what we're doing on the day to day.
Thank you, Shanika. Next up, we have Keith. Keith is a third-year medical student here at University of Ottawa. During the summer after his second year, he completed 2 weeks of anesthesiology and 2 weeks of endocrinology at Taipei Medical University in Taiwan as part of the international exchange program. On to you, Keith.
Thank you very much. Hi, everyone. My name is Keith, and for the next 10 minutes or so, I'll be talking about Taipei. Specifically, I'm talking about my international placement there, some logistics related to that exchange, my clinical experience there, some challenges I faced, practical considerations of the trip, and some highlights of the trip. And as a fun fact, almost all the photos in this presentation come from my camera roll. So as was mentioned, in the summer after my second year, I did 2 weeks of anesthesia and 2 weeks of endocrinology at Taipei Medical University, which is one of 4 medical schools at Taipei, also known as TMU. This is part of the IFMSA CFMS International Exchange Program, which is organized by the International Federation of Medical Students Association and the Canadian Federation of Medical Students. This is the iconic tower in Taipei, Taipei 101. This is the hospital where I worked. And this is a group of students I was placed with at TMU, who I will talk more about later. And hopefully during the course of this presentation, you'll get the impression that Taipei is a bustling metropolis with a population of 2.5 million. And as reference, population of Ottawa is about 1 million. During the program, I had excellent support from TMU students. About 2 to 3 were assigned to each student. And here's a picture of me with my helpers. I lived at these students, they met me at the airport. They answered my questions leading up to the program. During the month there, they also answered my questions and they recommended so many restaurants and activities to do in Taipei. I lived at a dormitory for international students, most of whom were doing research internships in the basic sciences, and they came from all across the world, but mostly Indonesia, Burma, Algeria, France, and India. And TMU students, they worked really hard to ensure that we had fun during our month there, because they would organize weekly events and day trips to help us explore Taipei and the surrounding areas. So for example, we would go to a restaurant together, or we would go explore a night market. I'll explain later what a night market is. So basically there's a ton of food there. There was some day trips to tourist spots to Shifen Waterfall and Shifen Old Street, where we got to decorate a sky lantern and release it into the sky. There are also 2 weekends where we got to meet other exchange students staying in other Taiwanese cities. First was a traditional Chinese medicine camp in Taichung, and second was a social weekend in Tainan. Both these are cities along the western coast of Taiwan. I'm definitely not biased, but Taipei and TMU in particular was one of the best locations because there was just so much to do in the city, and the students worked very hard to ensure that we made the most of our month there. However, the majority of the time was spent in clinical duties. My anesthesia placement was 8 days, and I spent over 85 hours in the hospital. Here's a picture of the lobby of the hospital. And here's a picture of a daily schedule, which is obviously in Chinese, but from the times on the side, you can get an idea of what the hours were like. So normally we start around 7:20 a.m. with a morning meeting to discuss the surgeries of the day. Then we might have a lecture, for example, on airway management or a workshop related to that. Then we would have some time in the OR where we practice bag masking and sometimes intubating patients. And then we would have some more workshops and lectures in the afternoon. For example, here there's one on IV anesthetic drugs, and another one, this one's an airway management workshop. Earlier we had a preoperative assessment lecture. And then there are also classes in the evenings, but I do not know what those are about because I refuse to attend those. I want to go home and sleep. Most of the activity, all the clinical activities, took place in an operating room, in the hospital, in conference rooms, or sometimes in a pain clinic. But I do want to emphasize the majority of the activities were observation, and this makes sense when you compare Taiwan and Canada's medical education system. So in Canada, after you finish high school, you start undergrad for 4 years, whereas in Taiwan, you go straight into medical school. So you're studying basic medical sciences. Then you become a clerk for 2 years. You are now in the hospital and you have some clinical duties, but the majority of your learning is still these lectures and workshops. During that time in Canada, we are pre-clerks. Then we enter clerkship, whereas in Taiwan, they start postgraduate year training, where they're technically residents. They just don't have their medical specialization yet, but they do have much more clinical responsibility. And then finally, in both countries, we become residents. We choose our medical specialty. So it's because I had finished my pre-clerkship, I was working with other clerks in anesthesia over there. So we were definitely in the hospital, but we were still mostly attending lectures and workshops and still doing some clinical activities. This was by far enough for me because everything was also in Mandarin, and I did not speak Mandarin heading into this program. That's definitely a challenge I'll talk about more later. After anesthesia, I did 2 weeks of endocrinology, and just from the empty space in the schedule, you can tell it's a lot more relaxed. Usually in the mornings, I would go to an outpatient clinic and see the doctor interview over 90 patients in 3.5 hours, or I would go to grand rounds or lectures that took place in a small group, or even a smaller group of one-on-one with a resident. And then sometimes in the afternoon, I would observe some thyroid ultrasound. So the biggest challenge by far was the language barrier. Knowing Mandarin is not required for the program. The majority of the students, the international students, were from Europe and they didn't speak any Mandarin. But I felt like if I didn't try to learn, I wouldn't get as much out of the program. So for 8 months leading up to the program, I used Anki, which is a flashcard program to learn Mandarin vocabulary. Every day I studied Chinese grammar, I practiced reading, speaking, and listening, and by the time I reached Taipei, I was conversational. As context, I also speak Cantonese, so it helped me pick it up faster. But like I was able to text my TMU students and my residents in Mandarin. I could like converse with people. I could attend medical lectures and pick up enough to like take notes during them. So all is to say, like, you don't have to learn Mandarin. You can definitely like have a very fun month there, like if you don't speak any. But I definitely felt more integrated because I learned the language. Another challenge that was a bit harder to overcome was the climate. Summer in Taipei is usually 35 to 40 degrees Celsius. And at the end of the month, there was a typhoon. Unfortunately, Taipei was not the epicenter. I basically just got to stay home for 2 days and miss some work. And another big challenge was being outside my comfort zone. I was in a different country, speaking a different language. I was like spending all my time in a hospital, and at that point in my training, I was not used to that. And at the end of the week, at the end of the first week, I felt so uncomfortable, like I wanted to go home. But I remember that the last time I felt so outside my comfort zone was during my previous exchange program when I was in Quebec learning French, and this was like before university. And even though that experience, like I was outside my comfort zone, I grew a lot from that experience and it was very formative. So I reminded myself that being outside your comfort zone is a good thing. It contributes to your personal development. And this summer was one of the most fun and most formative in my life. And I really, I'm very grateful for having the opportunity to do this. A final challenge was sometimes the program's a bit disorganized on the Canadian side, but that's just because the program was paused during the pandemic and this is the first year they're resuming it. As students participate more every year, like it should become like more organized, and you just have to go in with the attitude like being flexible, and like once you're there, you get great support from TMU students. The main ethical consideration is like considering why you want to go. This is not a humanitarian mission. From these pictures, I was trying to convey that Taiwan is like a first world developed country, and Taipei in particular is very advanced. This is a picture of Taipei main station, which was like a 10-minute walk from a dormitory. And during the first week, every time I went there, I got lost because it has 10 stories and it connects to 4 underground malls. And along the west coast of Taiwan runs a 200-kilometer high-speed rail. I went on this and came back and went on via rail, and it was definitely not the same. And so my main reasons for going were to learn Mandarin and to explore different healthcare systems. So I encourage you to reflect on your reasons why you would want to go before you apply. You should also be open to exploring a new culture. You don't have to learn Mandarin, but you should try to learn a little bit while you're there. You should explore the new food there. I have a slide devoted to that. Taiwan has a lot to offer. And you should respect different customs. For example, in Taipei, you can't eat in the metro or like even in the metro station. You're supposed to wear your white coat in the hospital. And like for example, when you're eating with chopsticks, you should never stick them vertically in a bowl of rice because it connotes death. So these are just parts of like customs that come with going to a different culture, and you should make sure you respect those when you're there. One of the biggest highlights of the trip was the friends I made. So this is me with all the other international students from TMU. They came from Sweden, Brazil, France, Austria, and Estonia. There was also a guy from Switzerland who had arranged his own elective at TMU outside of this program. But we found him in the hostel one day and we started hanging out with him. I have so many fond memories of exploring Taipei with this group, and we still keep in touch through WhatsApp and Instagram. And actually, some of them are in this call right now. I believe Barbara is beaming in from Brazil and Eliza from Austria. So thank you very much for coming in. I know it's very late where you guys are. And I also have a picture with the international students in the dormitory where I was living because I also befriended them. So overall, like I'm so happy now that like I have friends all across the world, and hopefully we can reunite on some continent in the future. Another huge highlight was the food. Taiwan has so much to offer. They are known for these night markets, which are just streets lined with dozens of food vendors. Taipei alone has over 30 night markets. This is a picture of my favorite one called Raohe. Taiwan is also known for beef noodle soup, hua bao, which is like a pillowy bun with some pork inside. These pepper cakes, they have a beef filling. They're cooked in like a cylindrical clay oven. And of course, bubble tea. Taiwan is the country where bubble tea comes from. So scattered throughout Taipei, there are also several Michelin star and big gourmand restaurants, and I was able to go to most of them because food in Taiwan is very cheap. Every day I would eat like 3 meals, snacks, desserts, and I would spend probably less than $25. When my friends and I were not busy eating, we were busy exploring because Taipei has something for everyone. Here is the picture from the top of Taipei 101. I spent a day hiking in Yangmingshan National Park. That's where a picture of this grassland and the mountain view comes from as well. There are several museums in Taipei, such as the Fine Arts, Art and History, and Natural History Museum. Several temples in the city. One of the more famous ones is Longshan Temple. There's great shopping in Taipei. This is Uniqlo, a Japanese clothing brand. My favorite store, however, was S-Light, which is like a Taiwanese bookstore / department store, kind of like Indigo, but like far superior in my opinion. In Taipei, there are about 9 Uniqlos and 8 S-Lights, and I went to all of them during my month. I love them so much. There are several national monuments in Taipei, such as Chiang Kai-shek Memorial Hall. There's a small mountain on the eastern edge of the city where you can get great sunset and sunrise views of Taipei. And you can take a day trip to a nearby tourist spot called Jiufen Old Street. If anybody has watched the Japanese film Studio Ghibli by the Japanese film Spirited Away by the film Studio Ghibli, this is allegedly the place that inspired that movie. So reaching all of these places is very easy in Taipei because the metro is fast, reliable, and frequent. And I was frankly astounded because going in, my baseline was like OC Transpo. So overall, the highlights of this trip combined with my clinical experience made it truly one of the most unforgettable times. I'm happy to answer any question. Thank you very much for listening.
Thank you for sharing all that. I can't imagine seeing 90 patients in 3.5 hours.
Yes.
And before the usual sort of ascribing it to lack of patient-centeredness, I don't think that's the full truth. Is there anything we can learn from that? Is there anything about efficiency, integration? You mentioned those things that you're bringing home.
For sure. I think the biggest point is efficiency. So one of the biggest differences between the healthcare system when it's there in Canada was just patient load. Some people could argue that each patient interview was like 3 to 5 minutes, and you might argue like a lack of like patient-centered care is there. But also, I think you have to tailor your delivery of care to the patient's expectations. So in Taiwan, like they're fine with that because they go in, they want to know like what was their HbA1c, and it's like what's the doctor going to do in response to that, and then truly that conversation only takes like not that long, and then that's all they want from the interaction, and then they can go about their day. So I think that we can pick up from this efficiency how, of course, patient-centered care is very important, but it's like sometimes it's not always required depending on what the patient expects from the interaction. And that's just like the system they have to deal with because of their massive patient loads. And obviously it works well for them because their healthcare system has functioned for decades. So I think efficiency would have been the biggest thing I took from that.
I'm curious to know more about your language learning and how you kind of integrated that into time and pre-fellowship. I know it's a busy time for most med students. So do you have any tips for people that are preparing to go on exchange and want to learn a new language?
For sure, yes. That was like a side quest during my second year, and I really enjoyed learning it. So because I also like speak French and I learned that during my high school university, I went in with kind of like a knowledge of like how you go about learning a language. In my opinion, you need like a 5-point strategy. You need to learn vocabulary, reading, writing, speaking, listening. You need to study these consistently over a long period of time, which is why I was doing it like daily for 8 months. When it comes to how you first approach it, I think first you should identify what kind of level you're at, for example, through a diagnostic test, and then you need to set a goal of like where you want to reach. So for example, for Mandarin, there's something called like HSK standard, which is like in French, if you've heard of like DELF levels, this is kind of like the equivalent for like Mandarin. So it's HSK 1 to 6, and I think when I started, I was like HSK maybe like 1 or 2, and my goal was to reach like 3 or 4. So making sure you set a goal for yourself that's reasonable, I think is very important of the language learning process, tackling it in that like multi-pronged approach. And then you can also, speaking if possible, try to listen with I try to practice with like native speakers. So I managed to pull this off by 2 of my classmates want to learn French, but they also spoke Mandarin. So it's just like, how about every week I teach you French for 30 minutes, you teach me Mandarin. And we did that for 8 months, and that really helped learning how to like speak naturally. Additionally, with when you learn vocabulary, very important to pay attention to the connotations of words because some words, even in English, are more formal. You use them when speaking with a professor, whereas when speaking with your friends, more casual tone. Same thing applies to any language. So oftentimes, whenever I learn a new vocabulary word, I would screen it with like my Mandarin speaking friends being like, is this the word like you would normally use every day? And be like, yes or no, or like, oh, that sounds like too fancy, like that sounds very like coarse or whatever. So that's how I tailored vocabulary learning. And then also for listening, try to listen to as many different speakers as you can. One mistake I made was I didn't realize that Taiwan people have their own accent. So when I landed in Taiwan, at first I was like, I can't tell if people are saying a word I don't know or they're just saying a word I do know with an accent. And it was like very difficult at first to like adjust to that. So like if you're trying to learn a language, be cognizant that there might be different accents, but overall it was like a very fun challenge, and like I gained a lot from that experience. Yes.
Anything you change in your strategy of studying or how you plan to practice medicine in the future after you visited Taiwan and learned about their culture in medicine?
For sure. I think now I am more committed to helping patients in the future who speak Mandarin or Cantonese. This is so even now, like after my exchange, I would say now I'm like pretty fluent in Mandarin. It's like it's gone down a little bit because I don't use as much, but like during my clerkship rotations, I've been able to help Mandarin patients, and I like. Same thing with when you help like any patient who like is not receiving Canada preferred language. Once you speak to them in that language, you just see the relief wash over their face, and like I definitely see this gap, for example, from like my own family. Like sometimes my parents, they really want access to like a Chinese speaking doctor because they want to be able to communicate in their language. So I hope that in the future, like I definitely need to like work more on my Chinese and Mandarin, but hopefully one day I can help fill that gap in my practice.
Would you concentrate on learning languages yourself or also trying to implement more translator services in the hospitals or clinics where patients are coming to?
That's a good point. I think that ideally I would do both. I think I have more control over my own efforts by, I think like, of course, advocating for better translation services in the hospital is very important as well. I mean, right now we have like iPads that you can like wheel into the room. I've used those during my clinical rotations. It's like sometimes a bit clunky just because like you're dealing with like a third person who like might not hear the conversation in real time. But I think it's also a pretty good like practical solution. Of course, I think the best translator service is like you have another person in the room because then they can like react like very live in live time, and they can contribute nonverbal communication as well. But I think I would mostly focus on my own efforts to learn the language, and then hopefully, like in the future, I can act as that like third person translator in the room if I need to. Yeah.
Thank you, Keith. Our next speaker is Chelsea. She is a second-year medical student at University of Ottawa, having graduated with Bachelor's of Health Sciences from McMaster. She's passionate about advocacy and addressing stigma in healthcare, particularly in relation to substance use. As part of her community service learning placement, she collaborated with Ottawa Public Health and CAPSA on a project focused on improving healthcare interactions and fostering a more supportive approach to individuals affected by substance use. Through this initiative, she worked to implement person-first language and explore the impact of stigma on patient care, ultimately aiming to improve healthcare access and outcomes for individuals affected by substance use. Her work continues to inform her understanding of the importance of holistic, non-judgmental care in building trust with patients. So unfortunately, she's unable to join us today, but she has pre-recorded her presentation for us, which Leah, if you're ready, you can play.
So if anyone has questions for Chelsea, we'll be sharing an email, so you can send your question.
Hi, everyone. Thank you so much for coming to this Global Health Learning Network event. I'm sorry I can't be there in person, but I'm hoping that this video can make up for it. My name is Chelsea Zhang, and I'm currently a second-year medical student at the University of Ottawa. And today I'm really excited to share a little bit about my experience last year when I worked with Ottawa Public Health, or OPH, and CAPSA to explore how stigma impacts substance use health and the way healthcare professionals interact with their patients. So I originally got involved with this project through my CSL, or community service learning requirements, alongside a group of around 20 other students. And the idea was to work alongside OPH and CAPSA to explore how stigma affects access to care. So we focused on applying principles of substance use health in health assessments, building our skills in person-first language, and learning how to recommend appropriate health and social services for patients dealing with substance use. And our end goal for the project was to understand how the language we use in healthcare settings, rather than perpetuate stigma, can instead foster trust, respect, and openness with patients. So why was stigma within healthcare the focus of this project? So what I came to understand is that stigma can be one of the biggest barriers preventing people with substance use challenges from seeking care. When we first started the project, this article written by Molly Frost that I have here on the left was sort of the basis of how stigma can impact patients. If patients feel judged by their healthcare providers, it can affect not only how they interact with the healthcare system, but also whether they'll seek care when they really need it. My project had several stages. The first part was training. This was all about getting oriented with the project and understanding the language surrounding substance use health. So all of us completed training modules, in-person sessions, and we learned about topics like preventing overdoses, harm reduction, and the impact of language on mental health. The training was a great intro to understanding how something as simple as the words we use can affect communities' perception and accessibility to care. Next, we worked on developing resources for our classmates, and this involved analyzing fictional case studies where we drafted care plans for hypothetical patients using person-first language. Person-first language being the practice of placing the person before their condition. So for example, instead of using the term lapses, we replaced it with recurrences because it doesn't carry the same negative connotation and it puts more focus on the patient. And that really helped me get a deeper understanding of how to incorporate this language into real-world healthcare settings. And at the end of the project, the goal was to create an online educational module that could be used by our classmates, by healthcare professionals to improve their understanding of substance use health and stigma. So all of our case studies, all of our care plans, all of our videos were all compiled into this module. So this is a screenshot of really the end product of my project being the videos of our cases that were used as educational resources. So for example, I was told that my patient was a 69-year-old female named Betty who was brought to the ER due to a suspected kidney infection. And we knew that she also had chronic cirrhosis of the liver. This case could be a bit tricky. It would have been super easy to just focus on the cirrhosis without considering the broader context of Betty's history or perhaps ongoing substance use. Even though the medical team might be hesitant to ask about alcohol use or substance use, not addressing it could also limit the effectiveness of her treatment. And I also had to consider that Betty might be ashamed to discuss her substance use, so I would have to approach the subject with sensitivity. I really think one of the highlights of this project, especially at this point, was the collaboration. You know, being able to work with fellow students to film our case reports, as well as having healthcare providers sort of overseeing the whole thing and looking over case reports, gave me a good understanding of how interdisciplinary work can really help tackle complex healthcare issues. So as sort of an aside, this was not originally part of the project, but I also had the privilege of showcasing my work at the City Studio Hubbub 2024 exhibition, where my project won both the Top City Studio Ottawa Project Prize and the Hubbub 2024 City Staff Award. That was really the highlight of the year for me, to put it mildly, and it was an incredible chance to get involved with advocacy with the local community. Getting to discuss this subject with politicians, Mayor Sutcliffe being on the left, was just an incredible honor, and it was sort of a full circle moment for me to demonstrate my scope of knowledge surrounding issues with substance use and stigma in Ottawa. So I think there are a few main takeaways from my experience that I sort of want to leave everyone with. The first is to always try to explore every opportunity to learn and go outside your comfort zone. You never know where it might lead, and I think my project with Hubbub is a perfect example of this. I never expected it to go as far as it did, but I'm so glad I pushed through because it opened so many new doors. Second, I think it's so important to keep an advocacy mindset. As future physicians, we'll find ourselves advocating on both an individual level, namely advocating on behalf of our patients, as well as a systemic level. And I think seeking out activities like this can be a great avenue into health policy and advocacy. Lastly, I hope everyone remembers the importance of holistic patient-centered care. So speaking as a pre-clerkship student who will be transitioning to clerkship soon, I think we can easily get lost in the routine of classes and exams as we try to learn as much as we can before working with patients, and rightfully so. But I think it's also important to remember that there's so much to healthcare beyond just memorizing facts. There's also a real person with their experiences who might have faced stigma before when trying to get help. So we should always be mindful of that. So that brings us to the end of my presentation. Thank you all so much for listening. And if anyone has any questions, feel free to email me. Have a great rest of your day, everyone.
Just gonna check if there are any questions in the chat. Okay. If anyone has any further questions to the previous speakers, feel free to ask them now. Otherwise, like each time we do a session for the Global Health Learning Network, we like to hear back from you how you found it. So you could just scan the QR codes, whether in English or in French, and complete the evaluation form. That would help us into making more Global Health Learning Network events and ones that are more interesting for you.
So in view of wrapping up, I just want to thank everyone for coming. We're going to hang out for a few minutes to see what ideas you might have for next year's series. I was trying to think of what's the connection between the four presenters. Excellent talks, thank you. I think it comes down to values for me, the connections, you know, the reciprocity, equity, respect, communication, and social justice above all. So thanks so much for coming. And please have some more pizza. We're not taking any home. I have too much pizza at home. I have three kids. So please help yourselves. And thanks to the whole team for setting this up.